Hello, this is Dr. Christopher Hyer from the Orthopedic Foot and Ankle Center in Columbus, Ohio. I'm here to talk to you about the Osteofiber Trimmable Fixation Nail System and show you how we use it for scarf osteotomies. The Osteofiber Trimmable Fixation Nail are a first-of-its-kind implant material, stronger than cortical bone, and allows for early bone attachment, bone ingrowth, and complete replacement. The hexagonal and barbed trimmable nails can maintain compression, provide stable fixation strength, and prevent rotation. The ability to trim the implants to any desired length enables customization to any patient anatomy and adaptability for a wide range of surgical techniques and indications in the forefoot, midfoot, and hindfoot surgeries. The Osteofiber Trimmable Fixation Nails are currently available in a 2.4 diameter with 30 mm and 50 mm lengths and a 4.0 diameter and 50 mm lengths. The nails are packaged with sterile disposable instruments including two 1.1K wires, a cannulated drill bit, a depth gauge to measure the tunnel length, and an insertion sleeve and tamp to insert the implant within the tunnel. Sterile disposable instrumentations can be quite helpful in a surgery center setting where we have limited storage capacity, we have high turnover of trays, and this just adds to a very efficient and clean implant process. So we're going to go ahead and walk you through a short scarf type osteotomy used for a bunion of the first metatarsal. In my hands, I prefer a medial approach for our bunion osteotomies. This allows both improved cosmesis and allows good direct approach to the scarf osteotomy. We do careful dissection here, carefully elevating your dorsal and plantar flaps, taking care to reflect and protect the cutaneous nerves here, both dorsally and plantarly. At this point, we've got good dissection and creation of the flaps. A self-retainer is placed. I favor doing a medial capsulorrhaphy, taking out a little bit of the redundancy of the hypertrophied and lax capsule. We do this full thickness down to bone to help both with soft tissue attenuation and closure, but also this helps to rotate the sesamoids around in the frontal plane if there's any translation there. So you can see that wedge is resected full thickness. At this point now we're going to be basically beneath the capsule, beneath the periosteum, and doing a subperiosteal dissection. Here the flaps are created. Again, you're right against the bone. You'll be able to peel off the collateral ligaments around the medial collateral. So here we're creating the plantar flap, releasing the medial collateral ligaments off the medial eminence. We're using the self-retainer again, which is protecting neurovascular structures as well now as the extensor tenon and the capsular flaps. We'll make sure that enough release is for the osteotomy. Here, by plantar flexing the toe, you can put the plantar structures under laxity so you can release the medial collateral ligament if needed. And then because we are doing a distal osteotomy, we will need to have a little bit of soft tissue reflection laterally so that we're not caught up when we try to shift our osteotomy. Here we're going to do the distal osteotomy. We're going to resect our medial eminence. We'll make this in a slightly dorsal lateral plantar proximal direction to give us a flat surface to make the distal scarf. This will allow some slight plantar flexion of the capital fragment as we translate the capital fragment more laterally. So I prefer making the longitudinal or transverse arm of the cut first. Again, this will be now perpendicular to the flat surface that we resected the medial eminence with. So again, this is a short arm scarf technique for the distal osteotomy. You can use saline drip if you choose. Here, when we go to the distal arm of the capital fragment, I'd elevate the great toe so that this helps to bowstring and move the extensor tendons out of the way for the saw cut. You can use additional retractors here if you wish. We'll just make sure our transfer cut is going proximal enough. And then likewise, as we make the more proximal scarf cut, we'll plantar flex the toe again. That relaxes the flexor tendons and soft tissues. Usually as you complete the cut, you'll see an immediate shift as you've seen here. You can use a small osteotome or freer elevator, as is the case here, just to make sure that there's no additional bone cuts that need to be done, or that there's not any soft tissue attachments that would block the translation. At this point, we're going to then translate the capital fragment, as you can see has been done here. Sometimes a bone clamp or towel clip can be used to help shift the osteotomy. A reduction clamp is useful here to stabilize the osteotomy. In this case, this was just a towel clip and was not able to be clamped. As you see here, in this case, the osteotomy is quite stable on its own. So you'll maintain the shift, and then we'll use our included sterile 1.1 K wires to both stabilize the osteotomy and as pilot holes for the intended osteofiber nail. The surgeon's choice on the direction or angle of these pins and proposed osteofiber nails. So as you see, we've drilled over the first K-wire. The K-wire then comes out. The drill hole does need to be bicortical. We've then measured with a standard depth gauge, and at this point you can then insert the osteofiber nail with the inserter and tamp. You will be able to see the depth of the implant that you've inserted. You can then trim this with a saw, and then use the remaining pin as a second point of fixation. Obviously, in osteotomies on the medial or lateral foot, you could have soft tissue reflection. You could see underneath the foot as well, but you can measure this to depth and cut the implant to depth if you wish. Again, traditional depth gauge, hook the distal cortex and measure the length of the proposed implant. I'll usually measure this line to line. You really don't want it to be sticking out planarly, proudly, as you wouldn't want with any kind of fixation device. I have found that it's a little easier to make this insertion if you already have the implant sticking a little proud out of the tip of the inserter before you start to tap it. It just finds its home a lot easier. You can use the plunger as additional countersink if you wish. In this case, you saw we already had cut the implant to length before we inserted it. So there's really those two different options you can do. You can measure, put the implant in full length and then trim it off with a saw, or you can measure and trim the exact length of the implant on the back table and then insert it so it's flush. So this really gives you the option to do either. Again, the fixation maintains the compression that you've achieved with the reduction clamp or with the K-wires. As you can see, the fixation is stable to continue to maintain stability of the osteotomy. At this point, you would remove any redundant bone you wish and do standard closure per your technique of capsule, subcutaneous tissue, and skin closure. We follow a standard postoperative protocol with the scarf bunionectomy, whether it's fixated with a metallic screw or an osteofiber trimmable nail. We would have these non-weight bearing for 5 days in a compression splint. At the first post-op visit, then they would begin heel weight bearing in a boot walker for an additional week, and then go full weight bearing in the boot walker for approximately 4 to 6 weeks to allow for osteotomy healing, and then transition to comfort shoe as healing allows. Hope this was a useful video for you, and thanks for your attention.